Okay, let's unpack this. Welcome to the Deep Dive.
Glad to be here.
We're the show that takes these big, complex topics and, well, tries to boil them down to the essential insights you need fast.
And today we are doing a deep dive focusing purely on the shifting landscape of aging, and specifically the massive societal trends hitting geriatric nursing right now.
Right. And just to be clear for everyone listening, everything we're talking about today, it's drawn exclusively from Chapter 1 of the textbook, Basic Geriatric Nursing, 8th edition.
Exactly. No outside info, just what's in this foundational chapter.
Our mission here is pretty straightforward.
Yeah.
Give you, the learner, a concise guide, jargon-free, hopefully. Through this whole changing picture of aging in America, we're trying to synthesize the key facts, demographics, the economic side of things, and also these really deep ethical complexities that nurses, families, everyone is facing.
Yeah, it's a lot. We're starting right at the beginning. Like, how do we even define old? We'll bust some common myths. Look at the economic tightropes many older adults walk, and wrap up with some critical stuff around health policy, family dynamics, and the really tough issue of elder abuse.
Okay, sounds like a plan. Let's dive in. Section 1, defining the landscape of aging. So this word old, is there like a set age, or is it really just in the eye of the beholder?
It's surprisingly subjective, actually. The text makes a great point here. Chronologic age, just the number of years you've lived, yeah, it's the easiest thing to measure. But honestly, often the least meaningful. Like you said, perspective matters. Someone under 30 might think, oh, 63, that's old.
Right.
But ask someone who's already over 65. They often don't consider someone old until maybe 75.
That totally makes sense. I mean, we all know people who are chronologically up there but seem young, functionally speaking, and the reverse, too.
Exactly. Physically, mentally, age is more than a number.
But we still use one number all the time for government stuff, 65, Social Security, Medicare. Where did that specific number, that magic number, even come from?
Yeah, 65. It became the standard retirement age because of the Social Security program way back in the 1930s.
Okay.
But here's the kicker, the historical context that really shapes everything today. The average life expectancy for Americans then was only 63.
Wait, seriously? 63?
Yep.
So the system was basically designed assuming most people wouldn't live long enough to collect much, if anything.
Pretty much. It was designed to be, well, low cost. A vote winner maybe, but not based on longevity projections.
Wow. That explains so much about why the system is under such pressure now. We're living so much longer than it was ever designed for.
Precisely. We're victims of our own success, in a way, living decades longer. And that's why the full retirement age for Social Security is already creeping up, It's heading towards 67 for folks born in 1960 or later.
Okay, that historical context is crucial. Before we get into the demographics, though, let's quickly pin down some terms. For anyone new to this field, there are these 3 GER words that sound similar.
Yeah, easy to mix up, but distinctions are really important for understanding the field. First, you've got geriatrics.
Okay.
That's the medical specialty. It focuses specifically on the physiology of aging, diagnosing and treating diseases in older adults. Think of it as focusing on the abnormal conditions.
Got it. Medical, disease-focused. What about the bigger picture?
That's gerontology. It's much broader. It's the study of all aspects of aging, clinical, psychological, economic, social, the whole shebang.
Okay, gerontology is the wide lens.
Yeah.
And the third one, the one most relevant for nurses.
Right, that's gerontics, or gerontic nursing. This is about the holistic nursing care and services provided to older adults. The goal is promoting high-level functioning, comfort, quality of life. It's person-centered care.
Perfect. Geriatrics, gerontology, gerontics.
Got it. So if that's the professional framework, let's shift to attitudes, how society views aging. You mentioned America is pretty youth-obsessed. Oh, definitely. Our culture often treats old age as something to be feared or, viewed negatively. Wrinkles, gray hair, things to be fought against. Physical decline is seen as, well, almost shameful.
And that fear actually has a clinical term, right?
It does, gerontophobia. It's not just a personal dislike, it's a deeper fear of aging and even a refusal to accept older adults as part of mainstream society. Sometimes it leads to, well, frankly, odd behavior. Like the book mentions young people maybe getting anti-wrinkle treatments. It's driven by that phobia.
And then there's the prejudice we often see, maybe even unconsciously, in healthcare settings.
Exactly. That's ageism. It's the negative attitude, the prejudice, the discrimination based on the belief that getting older automatically makes people, unattractive, unintelligent, unproductive, all these negative stereotypes.
And the scary part is, The text points out healthcare providers aren't immune.
Not at all. And when ageism creeps into care, it leads directly to poorer health outcomes. It's a global problem.
So it sounds like fighting this starts with just basic facts, busting the myths. The book has a great section on this, box 1.1. What are some of the biggest misconceptions we need to tackle right away?
Okay, yeah, let's hit a few big ones. Myth number one, older adults are all the same. They're just one monolithic group.
That sounds dangerous in a care context, assuming everyone's needs are identical.
Absolutely. The fact is, they are incredibly diverse, probably more diverse than younger age groups because they've had a lifetime of different experiences shaping them. They become more unique, not less.
Okay, myth busted. What's next? Myth 2. They're mostly sick, frail, and, living in nursing homes.
Yeah, that's a pervasive image. But the fact, totally wrong. Most older adults live independently in the community. The actual number in institutional settings, like nursing homes, it's tiny. Only about 3% of those over 75. The vast majority are managing their lives.
3%. That's
Yeah.
much lower than I think most people assume.
Okay.
Third myth. Older adults are more depressed than younger people. The sort of grumpy old man stereotype.
Another common one. But the fact is, generally, they actually have lower rates of clinical depression than younger adults.
Really?
Lower, yes. Now, when depression does occur in an older adult, the consequences can be more severe, harder to treat sometimes. But the idea that most seniors are depressed? Simply not true according to the data.
So the core truth here seems to be personality doesn't just vanish with age. People are still themselves, maybe even more so, as the book says.
Exactly. It's the more so stage.
Right.
And successful aging, it depends heavily on attitude, on adapting, on meeting those developmental tasks throughout life.
And that connects to the quote the text uses, the serenity prayer.
Precisely. God grant me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference. That's not just advice for the person aging. It's crucial for caregivers, for nurses dealing with system limits. It's about accepting reality without giving up.
That's powerful.
Right.
Okay, let's shift gears to the numbers, the demographics. Because the sheer scale of change here is just massive, and it's driving everything else.
It really is. Think about historical life expectancy. Biblical times, maybe 20 years. Around 1900 in the U.S., only 47 years.
47, wow.
But then, in the 20th century alone, we gained about 29 years. By 2004, it was nearing 77.4 years. Now, okay, COVID-19 did knock recent projections back by about a year.
Right.
But the overall trend is undeniable. We are living much, much longer lives.
And the projections for the near future are pretty staggering. The book mentions that by 2034.
Yeah, 2034.
Yeah.
For the first time in U.S. history, the population over 65 is projected to be larger than the population under 18.
That's a fundamental shift in society structure.
It changes everything. And look specifically at the fastest growing group within that older population, the extremely aged, those 85 and older.
Okay.
That group is set to more than double. It was about 6.5 million in 2018. By 2040, projections are over 14 million. Think about the demand for long-term care, specialized services.
The strain on resources is going to be immense. And the main engine driving this huge wave is the baby boomer generation, right?
Yeah.
The age cohort born between 1946 and 1964.
That's the one. The sheer volume is hard to grasp. 10,000 boomers reach age 65 every single day.
10,000 a day.
Every day. This isn't some distant trend. It's happening right now. It's an operational reality for clinics, hospitals, social services.
Huge implications.
Yeah.
And within that older population, there are other disparities. Gender, for instance.
Yeah, there's an imbalance. Significantly more older women than older men. Around 29 million women over 65 compared to about 23 million men. This affects things like living arrangements, poverty rates.
And the book also mentions something called the Hispanic or Latino paradox regarding ethnicity and longevity.
Yeah.
What's that about?
Oh, this is really interesting because it kind of pushes back against simple assumptions about socioeconomic status and health.
How so?
The paradox is that, despite potentially facing more socioeconomic disadvantages, Hispanic populations in the U.S. generally have lower rates of premature death and actually higher life expectancies compared to both non-Hispanic white and black populations.
Huh. Why is that thought to be the case?
The thinking is that factors beyond just income or education are at play. Things like strong family and community support networks, maybe dietary factors, cultural resilience. These seem to play a really vital protective role in longevity. It's fascinating.
It really is. Okay, let's transition into the economic side of things, income, housing. We busted the myth of universal frailty, But what about the myth of universal poverty among older adults?
Yeah, that's another stereotype that needs nuance.
Hmm.
The financial picture is really varied. Some older adults are very financially secure, others struggle significantly. The median household income for those 65 plus was around $64,000 back in 2018.
So not everyone is poor, but poverty is still a real risk for certain groups.
Absolutely. The overall poverty rate was just under 10%, which isn't insignificant, but it really spikes for specific demographics.
Like who?
Older women living alone face much higher rates, and it's especially severe for older Hispanic women living alone. The text cites a poverty rate of nearly 38% for that group. Just crippling.
38%.
Wow.
And where does their income generally come from?
Social Security is a huge piece of the puzzle. It accounts for about a third of the total aggregate income for older adults. Pensions are becoming less common.
And that reliance on Social Security brings us right back to that funding issue we talked about earlier, the worker-to-beneficiary ratio.
Exactly. It's currently about 2.8 workers paying in for every person drawing benefits.
Okay.
But that's projected to drop to 2.3 workers per beneficiary by 2035. That's a massive structural funding gap looming.
Which underlines why government programs and legislation are so critical. Things like Medicare and Medicaid from 65, the Older Americans Act, even recent stuff like the CARES Act during the pandemic.
Yeah, the CARES Act, for instance, provided vital grants for things like home-delivered meals when seniors were isolated. These programs are lifelines.
The chapter mentions one specific financial tool for seniors who own their homes but might be short on cash, the reverse mortgage, or HECM. How does that work, and what are the downsides?
Right, the home equity conversion mortgage. It sounds good on paper, right?
Yeah.
You stay in your home, tap into the equity, you get monthly payments, helps folks who are asset-rich, cash-poor.
Sounds potentially useful.
It can be, but the risks are significant. The fees can be really high, and the big catch is the loan often becomes due if the person moves out for a year or more.
Oh. So if they get sick and need long-term care.
Exactly. If a serious illness forces them into a nursing home or assisted living for over a year, they might suddenly owe the full amount, potentially losing their house, their main asset, right when they need funds the most. It can be devastating.
Yikes. Okay, need to be cautious there. So, speaking of housing, despite those complexities, most older adults, about 78%, the book says, own their homes and really want to stay there, age in place.
That's the overwhelming preference. But home maintenance gets harder, accessibility issues crop up, so when staying home isn't feasible anymore, there are alternatives. Well, you have independent living or assisted living communities. Those offer private apartments, but with services available like meals, housekeeping, activities. Restaurant-style dining is a common feature.
Okay. More support than being alone at home.
Right. Then, on the higher end, you have things like life lease or life contract facilities. These often require a hefty upfront investment.
Big buy-in.
Yeah, big buy-in. But they essentially guarantee residents and access to increasing levels of care, including skilled nursing, for life. Provides peace of mind, but it's expensive.
And there are even more community-based models.
Yeah, things like group housing, unrelated people sharing a house, pooling resources,
Yeah.
and community-based residential facilities, or CBRFs, which offer supervision and services in a smaller, home-like setting.
And the book threw in a little did you know
Yeah.
about cruise ships.
Yeah, the cruise care option. It sounds a bit wild, but the point is, for some, the cost of continuous cruising with room, board, medical staff on board, and activities, it can actually be comparable to, or sometimes even cheaper than, high-end assisted living.
That's amazing. Shows how expensive traditional care has become.
What's fascinating here is that the sheer demand is forcing innovation. People are looking for diverse, affordable options, even unconventional ones, like house sharing or, well, cruises.
Okay, this leads us perfectly into the monster topic. Healthcare costs, specifically Medicare. The government program covering, what, over 61 million people now?
Yeah, 61.2 million and projected to hit almost 91 million by 2050. The costs are just astronomical. Medicare spending alone is projected to blow past $1.5 trillion by 2029.
Trillion. Okay, let's break down Medicare. It's got different parts, right? Part A.
Right. Part A is the hospital insurance. It covers inpatient hospital stays, skilled nursing facility care following a hospital stay, some home health and hospice care. But there are deductibles and limitations.
And this is where that DRG system comes in. You mentioned it briefly.
Yes, diagnosis-related groups. This system, started in the 80s, fundamentally changed how hospitals get paid by Medicare for inpatient stays. Instead of paying per day, Medicare pays a predetermined, fixed amount based on the patient's diagnosis group. The incentive for hospitals became efficiency discharge patients as soon as medically feasible. Hence the phrase quicker and sicker discharges.
Gotcha. Okay, so that's part A. What about part B?
Part B is the medical insurance component. It's optional. People pay a premium for it. It covers doctor visits, outpatient care, preventative services, medical equipment.
But it doesn't cover everything, right? There's a gap.
Right. Part B typically covers only 80% of the Medicare-approved amount for most services. The patient is responsible for the remaining 20%.
And 20% of major medical bills can be huge.
Exactly. That's why so many older adults buy supplemental insurance policies, often called Medigap plans, to cover that 20% coinsurance and other potential out-of-pocket costs.
Okay. Then there's part C, the Advantage plans.
Yep. Medicare Part C or Medicare Advantage. These are plans offered by private insurance companies that contract with Medicare. They have to provide at least the same coverage as original Medicare Parts A and B, but they often include extra benefits like dental, vision, and prescription drugs, Part D.
What's the catch with Advantage plans?
The main trade-off is usually network restrictions. You typically have to use doctors and hospitals within the plan's network, which can be more limited than with original Medicare.
Makes sense. And finally, Part D, prescription drugs.
Right. Part D is the voluntary prescription drug coverage. It's offered through private plans approved by Medicare. This is the part that used to have the infamous donut hole, a coverage gap where people had to pay a lot more out of pocket.
At that close?
Yeah, legislation effectively closed the donut hole by 2020, so the cost sharing is more predictable now, though drug costs are still a major issue.
So this whole system, parts A, B, C, D, D, it's incredibly complex and expensive, and the costs really spike towards the end of life, don't they?
They really do. The text mentions estimates that anywhere from 13% to maybe 25% of all the Medicare dollars spent on seniors are spent in their final year of life.
Wow. Which makes end-of-life planning not just a nice idea, but essential.
Absolutely vital. Competent adults have the right to make decisions about their future care before a crisis hits. That's where advance directives come in.
Okay, advance directives. These are the legal documents outlining someone's wishes if they can't speak for themselves. What are the main types we need to know?
There are two key ones. First is the durable power of attorney for healthcare. This is where you legally appoint someone, a healthcare agent or proxy, to make medical decisions for you if you become incompetent.
So you choose your decision maker. What's the other main one?
The living will. This document states your wishes directly about the kind of life-sustaining treatment you would or would not want if you become terminally ill or permanently unconscious. For example, wishes about ventilators or feeding tubes.
So one appoints a person, the other states your wishes for treatment.
Basically, yes, they often work together. And then there's another really important tool, especially in clinical settings.
What's that?
The POL-ST. Physician orders for life-sustaining treatment.
POL-ST. Okay, how is that different?
A POL-ST is an actual medical order signed by a physician based on conversations with the patient or their proxy. It's usually printed on brightly colored paper, so it's easily recognizable by emergency responders and other clinicians.
And it covers specific treatments.
Yes, very specific things like CPR preferences, allow, do not attempt, goals of care, comfort measures only versus full treatment, use of antibiotics, artificial nutrition. It translates the patient's wishes from a living will or discussion into actionable medical orders that are portable across care settings. Really crucial document.
Okay, that's super helpful.
Yeah.
Let's shift to the family side. With people living longer, we now have situations where 4 or even 5 generations of a family might be alive at the same time.
Yeah, it's a relatively new phenomenon in human history on this scale.
And this creates huge pressure on the generation in the middle, the sandwich generation.
That's the term. Yeah. Usually people in their 40s or 50s, they're sandwiched between the demands of raising their own children, holding down jobs, and increasingly caring for aging parents or other relatives.
It sounds incredibly stressful, a triple burden.
It is. And the source material points out a significant gender disparity here, too. About 75% of these family caregivers are women.
3/4.
And they often end up spending more time on the really demanding personal care tasks. The text even notes some projections suggest women may spend more years caring for aging parents than they spent raising their own children.
It's staggering. And that level of sustained stress, unfortunately, can lead to some very dark places, right?
Right.
Like the crisis of elder abuse and neglect.
Sadly, yes, it's a direct link often. When caregiver stress, physical and emotional exhaustion, financial strain, or even pre-existing family conflicts just overwhelm the available coping resources, abuse or neglect can happen.
And the numbers are alarming. The National Council on Aging estimates up to 5 million older Americans experience abuse or neglect each year.
It's a hidden epidemic, really, and what's truly heartbreaking, as the text notes,
Yeah.
is that the victim often doesn't report it. They might be afraid of retaliation, afraid of being put in a nursing home, afraid of making things even worse. Fear keeps it hidden.
So we need to be able to recognize the signs. The source breaks down different types of abuse. Let's go through them. Physical stuff first.
Right. Physical abuse is probably the most obvious: hitting, pushing, burning, using restraints inappropriately, actions causing physical harm. Then there's neglect.
How is neglect defined?
Neglect is more passive. It's the failure to provide necessary care, things like basic hygiene, adequate food or clothing, failing to get needed medical attention. But there's a key caveat.
Which is?
It's not neglect if a competent older adult understands their needs and actively refuses care or services. That's their right. Neglect implies the caregiver failed in their duty when the person needed or wanted help.
Okay, important distinction. Then there are the less visible forms, emotional and financial.
Exactly. Emotional abuse can be really subtle, hard to spot. Things like isolating the person, ignoring them, verbal assaults, threats, intimidation. Financial abuse is also insidious theft or misuse of money or property by someone the older person trusts. Look for things like unusual bank activity, missing valuables, sudden changes to wills.
And the last two categories.
Abandonment, which is just what it sounds like: deserting a dependent older person for whom you have responsibility, and then self-neglect.
Self-neglect. How does that fit in? The person is harming themselves.
In a way, yes. Self-neglect is when an older adult fails to provide for their own basic needs, maybe due to cognitive decline, depression, physical inability, or just lack of awareness. You see poor hygiene, malnutrition, unsafe living conditions, inability to manage medications or finances. It's incredibly complex because it involves balancing autonomy with safety.
So for nurses listening, the bottom line here is,
The nursing implication is crystal clear. Nurses are mandated reporters. In virtually every state, you have a legal obligation to report suspected elder abuse or neglect to the appropriate authorities, usually adult protective services. Know your state's specific laws and procedures. Reporting isn't optional.
absolutely critical. And beyond reporting, what about prevention? How can we support caregivers to prevent abuse from happening in the first place?
Prevention is key. The text highlights strategies in box 1.7. Things like providing respite care, giving the primary caregiver a break, time away to recharge. That's huge.
I can imagine.
Also, caregiver support groups, education on managing challenging behaviors, connecting families with community resources. And within institutions, things like creating a positive work environment for staff, managing workload stress, recognizing staff contributions, these help prevent burnout and potential neglect or abuse in facilities too. Reducing caregiver burden is paramount.
So wrapping this all up, thinking about the learner, the student, the nurse entering this field, what are the big takeaways from this chapter? It feels like we're at a really pivotal moment.
We really are. The major challenge defining geriatric nursing today is this collision course. The massive demographic wave of aging boomers hitting a system, financial, healthcare, social, that wasn't really built for this scale or longevity.
Right. Strain everywhere.
Yeah. So if we connect this to the bigger picture for you, the learner, the whole landscape is shifting. Care models are moving towards supporting independence for as long as possible, but also managing increasing complexity and chronic conditions.
So your role as a professional.
Your role has to be this careful balancing act. You need the clinical skills, obviously, but you also need this deep understanding of the economic pressures, the family dynamics, the ethical dilemmas around resource allocation. It requires compassion, advocacy, and a real acceptance of the systemic realities.
Your acceptance. Back to the serenity prayer idea.
Exactly. Accepting what you can't change, the funding limits, the sheer numbers, while having the courage to change what you can, the quality of care you provide, advocating for your patients, supporting families, reporting abuse. It's about navigating reality dynamically.
Absolutely. And, thinking about all this, the aging population, the caregiver stress, the rise of the extremely aged, it leads me to a final thought, maybe something for our listeners to mull over.
Yeah.
With technology like AI and remote patient monitoring becoming more common, how might that change our ethical understanding of neglect or even abandonment in the coming years? If an algorithm fails to detect a fall, or a remote system doesn't alert a caregiver properly, where does responsibility lie then?
Ooh, that's a really provocative question. When does tech failure become neglect?
Right. It's something we're all going to have to grapple with very soon.
A fascinating challenge indeed. Lots to think about.
Definitely. Well, thank you for diving deep with us today into these really complex but critical issues in geriatric nursing. To everyone listening, go out there, apply this knowledge, keep asking questions, and keep learning. We'll talk to you next time.